everybody on the committee. My name is Mel Beadle, and I'm here from the Central City SRO Collaborative. I'm going to say one thing. Stop. Don't make me choose every month whether I'm going to get my medication, whether I'm going to eat, or whether I'm going to stay off the streets or pay my other bills. Every month I have to do that. And there's many of my colleagues doing the same. So restore what you took from us back to us so that we can live a decent life.
Thank you. Next witness, please. 1 minute.
Good afternoon. I'm Sid Ipsi, member of SD Ankara. We strongly support the more budget for the SSI and restoration and SSP for senior people with disability and low-income group to alleviate poverty and hunger. That's it.
Thank you. Next witness, 1 minute.
Murray Hospital. I'm senior and disability action in support of restoring the SSI, SSP, Grand Cats and Cola. Thank you.
Thank you. Next witness.
Madam Chairwoman and members, Andrew Shane from the California Association of Food Banks. Another way to look at this debt, right, is that the state is now externalizing its costs. We always rail against corporations, right? You externalize your costs. Well, in this case, the food banks are keeping alive, and the pantries and the other charity partners, folks are being asked to live on an impossible budget of $900 a month. So we need to stop that and make everyone whole. Thank you.
Thank you. Next witness.
I'm on SSI. I live in San Francisco, which has the highest inflation rate in the nation. We've been bearing the burden of this inflation without seeing any restoration of these important, these awful cuts that have occurred. I wish you would see this actually more as an economic stimulus. All of this money goes directly into the local economy. It isn't a net loss for the state government. It's a net gain. You should look at it. It's much better than spending money on prisons, which don't benefit the local economy. They do an awful lot of harm. So please restore us back to the poverty level at least and higher, and see this as a net benefit, a double whammy and a double benefit, both to us who desperately need this. I would be homeless without this money, and we don't want that to happen. Thank you, Madam Chair, for holding this crucial hearing.
Thank you very much for participating in it. And our final witness.
Hello, Madam Chair. Thank you. I'm honored to be here today. I am a recipient of SSI, and I just ask that you just open your hearts and open your spirit and listen to the voices of these people that have come forward and shared their stories and shared their struggles, and show compassion and make a real change once and for all by increasing beyond the poverty level so people can just be able to live with integrity and dignity and feel confident and secure. Thank you.
Lovely comment to end on. Thank you very much. Appreciate all of the public comment on a very critical program. And Ms. Taylor, thank you for your testimony. We're going to move on to issues 6 through 10, focusing on in-home supportive services. We're going to start with an overview. We're going to move on to the oversight of the Fair Labor Standards Act implementation. Then we're going to hear about trailer bill language, budget change proposal, and then proposals for investment. I'm going to use the same strategy that we did in the last section. So for issues 6 through 10, we'll have public comment following the proposals for investment. So if you want to make notes, you'll have your opportunity to provide your comment to those, all those issue area sections. Let's go ahead and start with the overview of IHSS, and we are on page 14 of the committee agenda.
Madam Chair, thank you. Pete Chervinka again with Department of Social Services. First, on the next number of issues, I want to say thank you to staff who worked closely with us in preparation of a very thorough agenda. So I wanted to make sure to make that point, not just on these issues, but overall throughout.
I appreciate that.
So IHSS,
Why don't we just wait
Sorry.
1 second?
Yeah,
I think
absolutely.
people are leaving the hearing room, just so we can get some. All right, thank you. Go ahead.
all right. The sergeant handed you a PowerPoint. I'm going to go through 6 slides, and I'm going to hand it to our Deputy Director for Adult Programs, Eileen Carroll, to talk about CCI and the Universal Assessment Tool. So we'll be jumping from page 6 to 22 in the slide deck to stick with the agenda.
Got it?
Okay. Thanks again very much for the opportunity to be here today. The In-Home Supportive Services Program, IHSS, it's been operating in California over 40 years. It's our primary tool for keeping people out of institutionalized settings and maintaining them within the community in compliance with Olmstead. We're one of only 3 states in the country that has rebalanced its long-term care spending so that over half of that spending occurs in the community, and the vast majority of that, as you see on the last bullet, 95% of our home and community-based services spending occurs via the IHSS program. The next page, in the current fiscal year, we have an estimated average monthly caseload of 463,000 consumers receiving an average of nearly 102 authorized hours a month at a cost of roughly $1,300 a month, absent the impacts of overtime, which we just began paying on February 1. There's some demographics or statistics about the consumer population, and those are there for your information. Again, it serves age, blind, and disabled people in the program, inclusive, the last bullet, of largely a population of children with autism and other things who are younger. As we did for the SSI overview, there's a caseload chart on page 4 that gives you the graphic. You can see that in the 2000s, the caseload was growing at roughly between 5% and 7% per year. We hit tough fiscal times. There were a number of budget reductions in the program and so forth, and we've begun at the right side of that to return back to historical trends in the program going forward. The dotted blue line is the enacted budget. It's labeled as May revision in this chart, but it's the enacted budget projection, and we seem to be going right along with that and trending up quite significantly. On page 5 is a description of the program. 99% of it is federally eligible for federal financial participation from the Medicaid program. We get a 50-50 rate with the feds on the bulk of the program. And for the Community First Choice option for our relatively higher needs populations, we get a federal match rate of 56%. And that's fairly significant. We have a small state-only program that's now about 1% of the program, known as the IHSS residual. That's state and county funded. And with the implementation of the Coordinated Care Initiative in 2012, counties moved from having a fixed share of cost in the program to a fixed maintenance of effort obligation. On the last slide that I'll talk about for you, and in terms of an overview, there are a couple big things going on in the program that we'll talk about in the next few issues. The biggest one is that we're expecting the overtime costs to be almost $1 billion in the current fiscal year as a result of federal regulations. We also have, as I indicated, a return to growth in the caseload in the program of nearly $400 million. So we're projecting next year's budget for the program to be $10.4 billion. Not on the slide, the county maintenance of effort is just under $1.1 billion, and the state contribution from the general fund is just about $3 billion. So there's about $6 billion federal, $3 billion state, and about $1 billion and a little more than that in county funding for this program. And your agenda asks some questions about an update as well on the CCI, the Coordinated Care Initiative, and the Universal Assessment Tool. And Eileen Carroll, our deputy for adult programs, will take you to slide 22 of the PowerPoint deck.
So continuing in the overview, in 2012, the state enacted the CCI program, Coordinated Care Initiative. Starting in 2014 and 15, it has been implemented at the county level and continues to be so within 7 counties who are part of it: Riverside, San Bernardino, San Diego, San Mateo, Los Angeles, Santa Clara, and Orange. IHSS is considered a long-term service and support, along with other home and community-based programs under CCI. This program under CCI established new roles and relationships for CDSS with the IHSS program and managed care health plans, as well as the counties and public authorities. In 2015-16, we continue the integration and monitoring of the CCI requirements. The governor did extend the funding for CCI in 16-17. We collect it at CDSS and meet with the 7 counties and social services to monitor and collect quarterly statistics on how is CCI working. So are we seeing the benefits? Are there more referrals coming from managed health care? Are there what we call CCT teams, which is coordinated care teams, where they pull together managed care, social workers from IHSS and other programs to evaluate and coordinate a person's health, which also could result in increased hours. So we're measuring those outcomes, especially those that would be leaving nursing homes or other long-term care situations. We are doing this in combination with the Department of Health as we work with the coordination teams at the counties. Moving into the Universal Assessment Tool, this was created under CCI as well in 2012. It got started in 2014, the activities. We have a stakeholder group that was put into statute that has had meetings. We have contracted with the UCLA's Boren Center, a school for gerontology, to assist in the development of a draft tool, and that tool is meant for all home and community-based programs, but specifically under CCI, it's IHSS, MSSP, the CBAS program, as well as managed care. We have moved forward in the designing of this. There's still work to be done. I think we started with 3,000 level of assessment questions to be considered. It's down to 316. We're continuing to whittle it down to a 90-minute home assessment, but the assessment will reduce inefficiencies, duplications, replications among all the programs. So an individual who might be in every one of the programs only goes through this one time. We have continuing work that we are doing with focus groups to test the language and the benefits of the new approach, and those are going to begin in June of 2016. Moving from UAT, the other activity that's part of overview is the statewide authority. Again, as part of SB 1036, the creation of a statewide authority for the counties in CCI to have collective bargaining done through them. Started. We had the first meeting in February 23rd of 2015 of the statewide authority. The next meeting is planned for, it's coming up in June. I thought I had it here too.
I see July 1st for LA Riverside.
Okay. Yeah, we have a statewide authority meeting that is
I think
coming
we have a meeting coming up. with
August
authority.
6th.
Yeah.
Oh, no, that's a stakeholder advisory committee. July 15th, 2016. Bottom line, the statewide authority will be having a meeting coming up in June or July of this year. In addition to the authority, we had the creation and establishment of a 13-member IHSS stakeholder advisory committee. They have met the first time on August 6, 2015. There's a statutory requirement for membership that was followed. They are instituted to provide ongoing advice and recommendations on IHSS to the statewide authority, to CDSS, and to the Department of Health. Meetings convened for this group were October 23rd of 2015, January 15th, 2016, and their next meeting, again, is in July of this year. That concludes the overview.
Are you taking? And so, Madam Chair, members, that covers questions 1 through 3 on page 18 of this issue, and I believe our colleagues at Department of Finance are prepared to respond to question 4.
Okay. Colleagues from the Department of Finance, let's hear it.
Ong Law, Department of Finance. So with the recent passage of the MCO tax, further details regarding the administration's proposal to restore the IHSS service hours will be provided at budget May revision. However, the administration's position is that the restoration is in effect so as long as the MCO tax is operational.
Was that your recollection? My memory. LAO. Any comment? Any questions from members? Senator Stone.
So the MCO tax is going to restore the cut, is that correct? To make sure I understand that right.
So in the current fiscal year, the 7% was restored using state general fund in the budget bill as of as of August 1st, 2015. So it's been restored now. The governor's budget for the next year proposes a general fund restoration of it as well. And the point made by the Department of Finance is that the administration would be committed to continuing that restoration with general funds so long as the MCO tax, sorry.
The governor's Yang Lee, Department of Finance. Actually, the governor's budget includes NCO revenue, but given the NCO tax has passed without funding the 7%, we're in development of the May revision, and we'll provide that information once May revise is available.
So we'll hold the item open and hear about it post-May revise.
Could I just follow up with one?
Yes,
one more thing?
please.
Tell me how the increase in the minimum wage is going to impact all of this.
So for the bulk of the program, wages are collectively bargained at the local level. We have some counties below the minimum wage, below the new minimum wage, and they will be automatically raised to the minimum wage in those counties. Other counties already above the minimum wage are unaffected by that.
Okay.
And those changes happen automatically. For locally negotiated increases, counties, even with the MOE, have a local share of cost for the cost of locally negotiated changes in wages and benefits, but where the changes as a result of state law, like the minimum wage, the state and federal government share that cost.
Thank you very much. We're going to move on to issue 7. Oversight of the FAIR FLSA.
Okay. So if I can take you back then to the slide deck, and I can walk you through, beginning on page 7, in-home supportive services and the Fair Labor Standards Act, FLSA. I have a number of slides and information for you. This is probably one of the more complex issues before the committee, and I would be happy as we go along if you have questions to answer them as we go. The basic gist of this is that the U.S. Department of Labor promulgated a regulatory change to what's been known as the companionship exemption. They promulgated that change and issued the final rule. I'm sorry, I'm on page 7 of the PowerPoint.
Thank you.
Yep.
Just give me a quick second.
Yep, absolutely.
All right. We got you.
Okay, so effective October 1, 2013, that was the issuance of the final federal rule from U.S. Department of Labor that altered what's known as the companionship exemption under the Fair Labor Standards Act. The effect of that rule was to expand the application of overtime obligations and other items that I'll cover on the next slide to domestic workers, inclusive of in-home supportive services providers. After a series of court actions, California finally implemented the federal rule and began paying overtime February 1 of 2016. If we flip to page 8, when the final rule was issued by U.S. Department of Labor, the state enacted implementing legislation in 2014. There were 2 Senate bills here, and the major provisions of those are there. As I said, so key features of that rule: payment of overtime, the creation under the federal regs of compensation for travel time between 2 recipients on the same day, and obligation to pay for wait time, meaning when we paid somebody to go with their consumer or recipient to, for example, a medical appointment and they were waiting in the doctor's office, previous program rules didn't require payment for that waiting time. So the state implementing legislation authorized a provider to work up to 66 hours in a given week. Under the 7% reduction at the time, that was a 61-hour cap, but it's at 66. It allowed up to 7 hours per week of travel time and created and augmented recipient hours for wait time on their cases. It also, in recognition of both the complexity of the new rule and a desire to maintain the health and safety of recipients and avoid unanticipated impacts to their provider availability, a 3-month transition period, some people call this the grace period, and then it also required in situations where we had one consumer served by multiple providers or a provider who's serving multiple recipients to assist with scheduling under this cap. The statute required work week agreements. And on another slide, you'll see we have about 70,000 work week agreements signed and recorded in the CMIP system. There's a lot of folks in this program. SB 873 also created what's known as a flexibility or exception, and that's not an exemption, this is an exception. So if the needs of a consumer changed and they needed more hours in one week or the other, there was a defined set of rules that are really complicated to walk through that allowed them to contact their social worker and get approval to move the provider hours across weeks. Couple comments that I hope help with clarity. The implementation of the overtime rule, other than adding wait time for consumers' authorized hours, did not change or reduce the authorized hours for a recipient in the program. They are still entitled to receive the same services they always had. They continue to be in charge of hiring and directing and firing the worker that works for them. They're still the employer for that purpose. They continue to have responsibility to manage their hours as they always had. So when we talk about this program, there's really 2 caps in hours. If you're not severely impaired, as defined in the program, you have a monthly cap of 195 hours per month, but we usually talk about the program cap as 283 hours per month for severely impaired clients, and those are our high-need clients. If you take that 283 and divide it by the weeks in a month, that's how we got to 66. And the intent in the legislation when we enacted this cap was to ensure that in a one-to-one provider-consumer relationship, that provider would continue to be available to serve that consumer all of their authorized hours. And so that is the genesis of that particular number. the cap that we talk about and the exemptions that we're talking about to come, those are attached to the provider and not to a recipient. So a recipient has continued to be authorized for the hours that they always have been in the program. And I think that's an important point. Sometimes we talk about wanting to avoid jeopardy to consumers, and there are aspects of that, but their hours of service continue to be maintained. There have been a number of things that have been done. I'm now moving to slide 9 in the program. The next couple slides talk about the notice that we've provided, the instructions that we've provided, and there's only a couple of these that I want to call to your attention. And first I may add too, in 2014, the state prepared to implement the final Department of Labor rules, and we were planning to implement on January 1, 2015. And there was a massive training effort, a whole bunch of system change work, a lot of work with our county partners and labor organizations and advocate community to be ready to implement the overtime on January 1 of 2015. And it was late in December of that month, only a few days before we were going live, if you will, that the court action suspended the rule. So the rules of the program had been known for a little while, and a lot of the run-up since October, when the final of 15, when the last court action occurred, has been to update those things. We had a lot of great lessons learned from, for example, the training that we did. We did in over 1,200 trainings all over the state in preparation for the rollout of FLSA. We got a lot of lessons learned. We got together with our county partners, public authorities, the advocate community, and we developed what I believe is recognized as a really good training program for the run-up to the current implementation on February 1. Going back to the slide, in October, after the court action, when we decided to implement in California, we issued mailers and notices to recipients and providers informing them of the overtime that's coming, the workweek agreement requirements, the availability of travel time for those serving the same consumer on the same day. On December 1st, we issued a notice that the state would implement on February 1. And then the second to last bullet, at the end of January this year, we began to define the exemption criteria that we'll talk about a little bit later. There are other notices that we've prepared. On April 1, in the middle of this slide, I kind of bolded these for you, we issued the announcement about what we call Exemption 2, which is a very individualized exemption. And again, I'll define those later. The implementation of these regs is a big thing in the program. It increased the number of hours of service that providers can be paid for their consumers for wait time, attending medical appointments. It authorized the payment of overtime. You see payroll data on slide 11 for the month of February. We had 21% of our timesheets processed with an overtime payment. That's actually a little bit lower than we thought, but the number of hours is a little bit higher on each time card than we originally thought. But for those consumers with those providers working more than 40 hours a week, this is more money in their pockets, and we view that as a good thing for providers and the consumers that they serve. We have more instructions, of course, coming out. We have 2 draft all-county letters. That's what an ACL it refers to. As we do with all of our forms and instructions in this program and in other programs operated by the department, we engage in a robust stakeholder engagement process. We have conversations that educate even the drafts that go out for circulation, and then we put them out for circulation. Our usual effort is to have them out for public comment for 2 weeks, and so that we can take that comment and finalize it. In some cases, these were not out that long. Some days we asked even for 24-hour turnaround in some cases to meet deadlines. I want to acknowledge the collaboration from county partners, disability advocates, consumers and providers, and labor labor organizations, everybody who's providing input on these things to us, and kudos as well to our staff for managing that. This is probably one of the more complicated implementations this program has ever undertaken, and there's a lot of detail there. We know that it's not something that, 1 + 1 is 2 and we're done. We know it's going to be a learning process, and fundamentally we're committed to protecting the health and safety of the recipients of the services in this program as our first and foremost priority. Page 13 provides a few contextual facts for you. We've added, since early December, just over 30,000 providers to the program. In the program, those providers are paid every 2 weeks, and we get over 1 million paychecks that we process. I think that's not quite said the right way, right? We process 1 million timesheets every month. Right. So that word should not be paychecks, but timesheets. And for years in this program, every 2 weeks, every month, we exception out about 35,000 timesheets for errors of various kinds. And some of those typical errors are listed here for you. Not failure to sign it, illegible writing in the boxes, we can't tell what a number is, claiming hours beyond the recipient's authorized hours, and those require some kind of human intervention to process before they're paid. And we've been doing that in this program for years. Of note, with the February and March payrolls, we've continued to see roughly that number of timesheets exception out. And we view that as a good thing in terms of implementation, that we aren't seeing a lot more problems. Some of the things that we're going to talk about to you next is the reason for this third paragraph on this slide. We're going to be talking about exemptions and violations, and I want to put that in context. With 435 or 436,000 providers in the program, the entire conversation about exemptions and violations applies to people who are working more than the cap at 66 hours a week. So we're talking about a relatively small subset of the overall providers. That said, I don't say it to minimize the problem, because those people working that much generally have high needs clients, and their health and safety is the most at risk. As I said, the implementing state legislation required workweek agreements for these complex situations where we had one provider being served by multiple people, or or a provider serving multiple recipients, so that everybody knew who was available, what days of the week, and what hours to work. And we have about, as I said, 70,000 workweek agreements recorded in CMIPS 2. So on page 14, I'm going to talk now about exemption policies. The U.S. Department of Justice required states implementing the Department of Labor's final rule to provide individualized exemptions to the provider limitations in order to ensure compliance with Olmstead, the court decision, and the Americans with Disabilities Act. And California has 2 exemptions for these situations. The first one is an exemption for live-in family care providers. And I won't read it for you here, but it's for providers working in the program as of January 31 of this year, and describes the situation here. A provider that receives an exemption, and again, these are exemptions for providers, not for recipients. These are exemptions to the provider cap on weekly hours, may work up to 90 hours a work week, which is 360 hours per month. And the number at the bottom of the slide, we think there will be roughly 1,200 providers who successfully apply for the exemption. Exemption 2 is on page 15. Again, I won't read this for you, but there has to be a provider serving someone with complex needs, living in a remote or rural area where no other provider is available, or have a linguistic barrier between the consumer and any other provider. And for B and C, you don't have to be a live-in provider to receive the provider exemption. Exemption 2, both exemptions are approved at the state level by our department. We did a mass mailing for exemption 1, and that's in your list of ACLs. We did a mass mailing for exemption 1 and asked providers who felt they met that qualification to send back that form to us. It went to providers, it went to their recipients. Not remembering the mailing numbers exactly, it was 1,200 providers and 3,200 consumers, if I recall, received that notice. We've received, and there was a second round as well, please.
There was a second round of mailers beyond just the parents and the two grandparents, which was a broader mailing that went to 3,200 providers and their corresponding recipients. So it was targeted, but it also hit people it wasn't going to apply to, but there was no way to break out grandparents because there's not a category in the system for them. And as cases have come to our attention, because they were coded incorrectly by the county when they put it in the system, we're taking those cases and moving them rapidly through the process.
And we have some statistics for you after we get through errors. We'll talk about some statistics on those requests. Exemption 2 was announced on April 1. And I'll pause for a second to put some context around Exemption 2 for you. Because of the workweek agreement requirement to assist people in finding additional providers, because of the work that we're doing to ensure that that the consumer needs are still met by providers, because we are providing lists to counties of certain situations, and now, as of yesterday, to labor organizations as well, we are asking for their partnership in identifying situations that potentially cannot be resolved by an additional provider or some other accommodation. And we are asking Exemption 2 requests to be forwarded to us by the county. These are generated not by the provider, but by the county. They come to the state for final determination. Questions on anything so far? Yeah, please.